Good afternoon. The next topic will be on the RCC systemic therapy and cytoreductive nephrectomy. I'm Dr. Wu. I'm very great honor to be chair this session with Professor Lee Dong-hyung. Let's welcome the first speaker, Lu Jiawen.
Thank you, Chair and Co-Chair, for kind introduction. I'm honored to be here to deliver my part, the role of sequential targeted therapy. We know the treatment option for renal cell carcinoma has been revolutionized in a short period of time, but this rapid trend has left many unanswered questions, including the optimal sequencing of the therapy. We know more drug classes and prospects more to come in 2019, but more questions unresolved. So we must run as fast as we can catch up cancer care. We know that renal cell carcinoma is not a single disease. Also behave differently. In oncology community, we know the biology of the tumor is the key, and selection of the case is the queen. Professor Charles Swanton initiated renal cancer consortium. We explore the cancer evolution through therapy study. In their finding, that they explore the metastatic competency as a folded chromosome complexity, but not driver mutation role. Punctuality and branch evolution result distinct patterns of metastasis. We could optimize our therapy selection for metastatic clear cell renal cell based on medical comorbidity, prior therapy, tolerability, patient parameters, risk status, efficacy, and practice considerations. But our challenge ahead, how to accurately risk by the patients is a combination therapy is better than sequencing therapy. What's the activity of PD-1 blockade in the first line? Do we have many predictive markers, or are benefits outweighed by the cost? How about evaluating histology or renal cell carcinoma? We face the clinical dilemma in metastatic clear cell renal cell carcinoma treatment. So we must individualize therapy to maximize the clinical benefit. We have many normal to predict the patient prognosis factor, such as memorial sloan carrying MSKCC criteria or CCF criteria. We also have MD risk criteria, but we also know some predictors such as PPR11 and PPO1 associated with the prognosis. So could we integrate a genomic predictor into a clinical parameters? We can see we can update it, incorporate genomic annotated biomarker into the memorial sloan carrying cancer center models. We can group the patient into 4 groups: favorable risk, good risk, intermediate risk, and poor risk. We can stratify the patient more accurately and consult patient about their survival and disease trajectory, and design new clinical trial. So our treatment paradigm is shifting. With traditional classification and group good risk and intermediate into same group, but new treatment we group intermediate risk and poor risk. So we color Gaussian knot RCC treatment. We know historical efficacy associated approves first line treatment option for good to intermediate risk RCC group. So now we have an emerging first-line treatment option for NCC RCC as cabozantinib, nivo, and EP combination therapy. Also provide a good response. But we face a question of which and how. Usually TKI is first, or immunotherapy is first, single or monotherapy or combination therapy. So greater-map or androgens and immune associated gene correlate with the outcome. So we can correlate, but tumor mutation burden, neoantigen burden neither predict clinical benefit between the arms. PBR1 mutant improve outcome to sunitinib, but liver story tells us that PBR1 status may affect responsive to the checkpoint inhibitor. So we should more study to explore PBR1 status. So time is limited. So I'm just apply the 2018 ASCO education education book. When I say advanced unresectable RCC, we can risk stratify according to the IMDC criteria. Maybe consider PD-L1 testing, stratify favorable, intermediate, risk. Then we can depend on the PD-L1 expression to choose our option. So my takeaway message is that selecting the optimal first-line therapy for MCC RCC patient, sunitinib has a still role on favorable group. IO combination therapy is active in first-line setting for intermediate risk to risk patient. Cabozantinib shows interesting activity when compared with sunitinib. In terms of second-line therapy after failed first-line therapy, cabozantinib and nivolumab are standard of care option for other treatment failures. Both agents exert survival benefit over cancer everolimus. Due to lack of potential biomarkers, treatment decision should be made individual and balance toxicity and efficacy. And my talk.
Okay, thank you for Professor Lu. Very brief and outline. Due to the limitation of the time, I think we can complete the discussion after the three speakers. Okay, the next speaker will be Kwak, Professor Kwak from Seoul National University.
Thank you, Professor Lee and Professor Wu. It's a great honor for me to give a speech in this well-organized symposium. I'd like to give sincere gratitude to the organizing committee for inviting me. I will tell you the role of cytoreductive nephrectomy in the era of target therapy. In the cytokine era, two randomized clinical trials showed modest but statistically significant survival benefit of cytoreductive nephrectomy. Since 2006, more effective TKIs have been the standard of care for the treatment of metastatic RCC. However, the role of cytoreductive nephrectomy for patients with metastatic RCC remains controversial in the targeted therapy era. In National Cancer Database, containing 15,400 patients treated with target therapy, the median overall survival of cytoreductive nephrectomy versus non-cytoreductive nephrectomy patients was 17 versus 8 months. Overall survival was significantly better for cytoreductive nephrectomy group than non-cytoreductive nephrectomy group. And in cases of cytoreductive nephrectomy, overall survival was significantly better for post-target therapy nephrectomy group than pre-target therapy nephrectomy group. The meta-analysis showed that cytoreductive nephrectomy was associated with improved overall survival among patients with metastatic RCC in 10 non-randomized clinical trials, while one randomized clinical trial, Carmena, found the overall survival with sunitinib alone was not inferior to that with cytoreductive followed by sunitinib. In phase 3 trial, Carmena was published. Target was metastatic clear cell RCC with intermediate or poor risk. It showed that sunitinib alone group was non-inferior to nephrectomy sunitinib group with regard to overall survival. The median overall survival was 18 months in the sunitinib alone group and 14 months in the nephrectomy sunitinib group, and the difference was not significant. There were no significant differences in response rate or progression-free survival. Recently, another phase trial third time was published. Trial compared immediate nephrectomy then sunitinib and deferred nephrectomy after 3 cycles of sunitinib. Progression-free survival, the primary endpoint, was not different between two groups. In addition, the median overall survival was 32 months in deferred nephrectomy group and 15 months in immediate nephrectomy group. Although this difference was not significant, overall survival results were higher with the deferred nephrectomy group. With the deferred approach, more patients received sunitinib and overall survival results were higher. In Carmena and third-time trials, intermediate and poor risk patients were included. The exclusion of a favorable risk patient could be considered to result in a potential bias. And this situation may have contributed to the high proportion of patients with features indicating poor prognostic risk and the relative overall survival in these trials. In summary, upfront cytoreductive nephrectomy should not be standard management in patients with poor performance status for INDC or IMS risk patients. The cytoreductive nephrectomy still has a role in the management of metastatic RCC in patients with a limited metastatic burden, amenable to surveillance or metastasectomy, and potentially in patients with a favorable response or stable disease after initial systemic therapy. Data are lacking regarding the role of cytoreductive nephrectomy before immune checkpoint inhibitors. Thank you for your attention.
Thank you, Professor Kwak. We will have the discussion after the next speaker. Okay, the next speaker will be Zheng Yuan-Tso from Kaohsiung Chang Memorial Hospital. Professor Cheng, please.
Thank you for the committee to invite me to have a talk about cytoreductive surgery in the metastatic RCC, and thank you for the moderator. I also thank you for Dr. Kwak. His slide, the last sentence, shows there's no data in the current IO era for cytoreductive surgery before the immunotherapy. So in today's data, I will show you the historic data. The cornerstone of cytoreductive surgery in metastatic RCC is established in about 2 decades ago. It's a Flanagan published a randomized control study in NEJM show the nephrectomy plus interferon is better survival, offer the better survival compared with interferon alone. The median survival is 8.5 months versus 11 months. EORTC also published a 85% study, randomized control, to select the good performance patient. Also show nephrectomy followed with immunotherapy is better than immunotherapy alone. SWAT group show their retrospective study. Surgery plus interleukin-2 is better than surgery plus interferon, and better than interferon alone. However, all these studies is select the good performance status, and the patient have good liver function, renal function, no brain meta. The mechanism of good result is not well known, but the hypothesis is decrease the bulk of tumor can facilitate the activity of the immunotherapy. There is direct effect of primary tumor or paraneoplasty effect to contribute the cachexia or other symptoms that make patient performance is worse. So improve the performance status of patient may provide better tolerance and high probability of response to immunotherapy. Nowadays, we have a theory of remove cancer stem cell. We know a lot of patients receive radiotherapy and chemotherapy can eradicate some differentiated cancer cell, but the cancer will relapse if the cancer stem cell is not killed. Dr. Kwak also showed you the Kamena trial in last year, published in last year ASCO. They showed 150 patients randomized to nephrectomy followed with sunitinib, or you just use sunitinib alone. The data show the sunitinib alone is even better in survival. It shows 18 months median survival, compared with nephrectomy only 13.9 months, although the data is not statistically significant. However, in both groups, the nephrectomy group have 40 patients did not receive sunitinib, and eventually 16 patients did not undergo surgery. And in the sunitinib alone group, there is 11 patients did not receive sunitinib. Even more, this group have 38 patients underwent a subsequent nephrectomy. So this data should be interpreted carefully. Dr. Moser writes in editorial, show the Kamena trial, 43% patient had poor risk disease. This could compromise those patients' survival, and the data should be carefully interpreted. Nowadays, we know the IO target therapy has shifted to the IO therapy. It's from major the PD-1 inhibitor, even though the comeback or high dose interleukin-2 data is published in last year ASCO, and the combined IO agent is now maybe a future hope. In Keynote 426 study, we found that axitinib combined with pembrolizumab is very high overall response rate. There's a 73% overall response rate, and near 40% have complete response or partial response. However, most patients still have residual tumor. Now we have a lot of combination therapy, but we don't have any trial in nephrectomy. So how about the residual tumor to be treated? There's a slide not show. There's a study in phase 2 show the around 40% post-immunotherapy patients have the radical cystectomy. Around 40% have complete response, but there are still a lot of patients have residual tumor. So there's no conclusion, but my personal opinion, cytoreductive surgery remains the management of choice for favorable risk metastatic RCC patients who have good performance and a resectable primary tumor. Surgeons should always balance the risk harm in patients elect cytoreductive surgery. Thank you.
Thank you. Professor Cheng, this section is open for discussion. Any comment or any suggestion from the audience? Okay, Professor Kondo.
So thank you very much for your talk. My question is regarding cytoreductive nephrectomy. So the many trials showed equal overall survival between with or without cytoreductive nephrectomy. But in our experience, when we are looking at the patient who underwent the cytoreductive nephrectomy showed a very nice overall survival compared to the patient without cytoreductive nephrectomy treated with only sunitinib therapy. So in my experience, I don't want to stay away from cytoreductive nephrectomy for many of the patients. I think that many of the patients still are candidate for cytoreductive nephrectomy when we're looking at survival. But the patient actually in our series, the patient who underwent cytoreductive shows about 50% of survival after 5 years. So 45% of survival after 5 years surgery. So what do you think, when you're looking at your case, what would you like to perform the cytoreductive nephrectomy? Do you just abandon the cytoreductive nephrectomy forever?
I agree with you. When you look at the retrospective study, always have a patient selection bias will be discussed. But when you real world data, I think the cytoreductive surgery is good for those patients with good performance, especially we can remove possibly cancer stem cell. So I will offer the cytoreductive surgery to most of my patients.
How about the last speakers?
Professor Kwak.
So I agree with you, Professor Kondo. So I usually offer cytoreductive nephrectomy. People thinking about administration of systemic therapy. So sometimes we matter favorable response in stable diseases. So how long we continue the systemic therapy? So in that case, I recommend the patient to give cytoreductive nephrectomy. The third point, if the complete metastasis is possible, we think I'll try cytoreductive nephrectomy and metastastectomy. In some cases, they have not received the systemic therapy, but the selection bias is involved because of good performance and good status, I think.
Okay, Professor Lu, do you have any comment or answer for this question?
I think the patient selection is most important in terms of risk grouping, maybe poor risk or some major organ metastasis. We cannot perform metastectomy. This patient I may consider systemic surgery first, such as a brain mass patient or liver mass patient, because I believe that the prognosis is great. So I must consider metastatic burden and primary tumor.
Okay, due to the limitation of the time, I will move this to Professor Lee.
Thank you. Good morning, ladies and gentlemen. I'm Dr. Lee, and moderate the next session about urinary bladder preservation for locally advanced bladder cancer. We have 3 speakers, and we have little time. So after 3 speakers' presentation, and then we have the comments over the question time. First speaker, Kevin Lu,